Good afternoon, and thank you for joining us today for our February Spirit of Women virtual event. Today, we are joined by our cardiologist, Dr. Renee Muchnik. Your heart is a complex organ that often sends warning signs when things aren't quite right. Today, Dr. Muchnik is here to help us understand the messages your heart can be sending, potential risk factors, and warning signs of heart disease, and daily tips to prioritize your heart's health. Today, Dr. Renee Muchnik went to University of Pittsburgh School of Medicine, did her residency at Strong Memorial, and completed a cardiology fellowship at University of Massachusetts Memorial Medical Center. She is currently seeing patients at our Williamsport office. We are extremely happy to have her on our team here at UPMC. As a reminder, we have a Q&A available on the right-hand side of your screen. Feel free to submit any questions throughout the presentation, and we'll be sure to answer them for you at the end. Right now, I'd like to introduce Dr. Renee Muchnik. Feel free to go ahead.
Well, thank you for that lovely introduction, and thanks for the opportunity to be here today. Thank you for tuning in. I'm happy to talk with you about women's heart health and how women may present a bit differently than men when it comes to heart disease. First, I'd like to talk a little bit about the prevalence of heart disease in our country. Heart disease affects men and women. It accounts for about 650,000 deaths every year in our country. It is the #1 killer. Among women, heart disease usually causes about 300,000 deaths. 1 in 16 women over the age of 20 will have coronary artery disease, which is the most common form of heart disease. Coronary artery disease occurs when cholesterol plaque builds up inside our heart arteries, compromising blood flow to the heart muscle. So what is it about a woman's heart that makes it different from a man's? Scientists have discovered that estrogen seems to play the largest role in causing women to present a little differently in terms of their heart disease. Women, on average, present 10 years later than men when it comes to heart disease. And this is largely due to the loss of estrogen associated with menopause. Estrogen has many protective effects on our blood vessels. It helps to improve the function of our blood vessels, and it leads to less constriction, so that basically improves the blood flow to our heart muscle. Estrogen can also improve our cholesterol profiles. It raises the good cholesterol, or the HDL cholesterol. When we lose our estrogen during menopause, that's when our risk of heart disease goes up, because we lose these protective effects of estrogen. Another unique feature that pertains to women is that we have an increased prevalence of autoimmune inflammatory diseases such as lupus and rheumatoid arthritis. These diseases damage the blood vessels directly, independent of your cholesterol levels. And this is very, very important for young women to realize. So I'd like to talk a little bit about signs and symptoms of heart disease. Both men and women usually present the same. A pattern of chest pain is usually a presenting symptom of heart disease. Some people will experience chest pressure, tightness in the chest, sometimes with radiation of the pain into the jaw or down into the arm. Women will sometimes experience these symptoms during sleep, and their symptoms will wake them out of sleep. They can also experience their symptoms during emotional stress. Women can also present with fatigue, shortness of breath, nausea, abdominal pain, and lightheadedness. Diagnoses of coronary disease can be somewhat delayed in women or even missed because of some of these more atypical features of symptoms. So I'd like to talk about risk factors. It's really important to know your risk factors to know what kind of risk you're at for having heart disease. There are both modifiable and non-modifiable risk factors. Modifiable risk factors are those risk factors that you can change. They include things like high blood pressure, high cholesterol, diabetes, obesity, and tobacco abuse. Non-modifiable risk factors are those things that you cannot change. Unfortunately, sometimes we inherit genes that predispose us to heart disease, and it's tough to do much about that. But if you do have risk factors but don't have any symptoms and are still concerned about your risk of having heart disease, you may want to talk to your doctor about different testing. We often can do a coronary calcium score that can sometimes give you an idea of how many plaques you might have inside your heart arteries. The coronary calcium score is a specialized X-ray that's done in a CT scanner that, again, gives the physician an idea of how many calcium-containing plaques are in your heart arteries. The test takes about 10 to 15 minutes. It's very simple. If you have a score of 0, that means that you have no plaque in your artery and your risk of having a heart attack is extremely low. The higher the score, the higher the risk of heart disease. If you come back with a very high score, your physician may talk to you about additional testing like stress testing or additional medications such as aspirin or cholesterol-lowering medicines to lower your risk of having a heart attack. If a diagnosis of heart disease is suspected, either based on a calcium score or based on your symptoms, your physician will talk to you about additional testing. Everyone will get an EKG or an electrocardiogram. This test shows us the electrical activation of your heart. It can sometimes show us if you had a prior heart attack or if there's compromised blood flow to the heart muscle. Next, your physician may want to do a stress test. And the most common type of stress test is called an exercise treadmill test. This is when you walk on a treadmill when you're connected to an electrocardiogram. The electrocardiogram shows us if there's any compromise in blood flow to the heart muscle during exercise. Sometimes in women, there are a lot of false positive exercise treadmill tests. So women may be better off getting a stress test with imaging. So a common test we use is a stress echocardiogram, which is when an ultrasound is performed on your heart both before and after exercise so that we can compare how well the heart is contracting after you exercise. If there's part of the heart wall that looks weaker than another part of the heart, that can be a clue that there's not enough blood flow getting to that particular part of the heart. Another common stress test with imaging is known as a nuclear stress test. During this test, the patient's injected with a radioactive dye both before and after exercise, and then we compare how well that dye perfuses the heart muscle before and after exercise. If the entire heart is able to take up the dye, that's good news. It likely represents that you don't have any significant blockages in your heart. However, if you do see some dark spots on your images, that can indicate that you may have compromises of blood flow to a particular part of your heart muscle. If you do end up having a positive stress test, the next step will usually be a cardiac catheterization. This is a special procedure that's done in a cardiac catheterization laboratory by an interventional cardiologist. The interventional cardiologist will place a long catheter into a large artery, usually in your wrist, and thread the catheter up to the level of the heart, where the heart arteries come off to perfuse the heart with blood. The interventional cardiologist injects you with a contrast dye that fills the arteries, meanwhile taking X-ray pictures of the heart arteries to try to figure out where you might have blockages. If you do have any blockages in your heart arteries, the cardiologist can then place a metal stent inside the heart artery to open it up and improve blood flow to the heart muscle. If you do require a stent, your doctor will talk to you about different medications that thin your blood to prevent the stent from getting a clot inside of it. When people are found to have coronary artery disease and lack of good blood flow to the heart muscle, they can also be at risk of other conditions. For example, if someone has a heart attack, that can weaken the heart's ability to pump. And this can lead to a condition we all know as congestive heart failure. Patients with congestive heart failure can present with shortness of breath and fatigue. And this is usually because fluid is building up inside the lungs, the abdomen, the legs. You may need a medication to get rid of the excess fluid. Another condition that can result as a result of heart artery disease is atrial fibrillation. This is an abnormal heart rhythm. Usually patients will say that they can feel their heart racing or fluttering or skipping beats. It also can predispose patients to strokes because in this condition, the top chambers of your heart start to quiver instead of squeezing regularly. So blood can then pool inside these heart chambers, form clots, and if these clots are to dislodge, they can travel to the brain and cause a stroke. Women are actually at increased risk of stroke when it comes to atrial fibrillation. So it's really important that people talk to their doctor about the need for blood thinners in this condition. Another condition I want to talk a little bit about is called cardiac syndromax. This tends to be much more common in postmenopausal women. It's a very challenging, perplexing condition. It affects the small blood vessels of the heart and the blood vessels that lie deep within the heart muscle. So when women present with their classic symptoms of chest pain, often their stress test will be normal. They can even have a cardiac catheterization done, which doesn't show any heart artery blockages, but yet their symptoms will persist. Sometimes cardiac MRI or cardiac PET scans can be helpful for establishing a diagnosis of this condition. And there's another condition that tends to affect women more so than men, and it's called stress cardiomyopathy, also known as Takotsubo syndrome. In fact, 80% of patients with this condition tend to be women. The condition will mimic a heart attack. Patients will come in with severe chest pain, shortness of breath. Their EKG may even show a traditional heart attack, but when they're taken to the cardiac catheterization lab, no blockages are found in their heart arteries. Instead, the heart muscle weakens because of toxic effects of circulating stress hormones. This condition usually happens after a stressful event like losing a loved one. What's important to know, and fortunately, after time and with appropriate medical therapy, your heart can recover function and return to normal. So now that we've talked about a couple of different types of heart disease, I'd like to talk a little bit about treatment. As mentioned earlier, it's important to prevent heart disease before it begins. So this is done by knowing your risk factors. It's important to be aware of your blood pressure, blood cholesterol levels, and blood sugar levels. It's important to eat a heart-healthy diet, get plenty of aerobic exercise. You should really focus on lowering your stress levels and getting good amounts of sleep, roughly 6 to 7 hours a night. If you are found to have heart disease, though, we have plenty of medications available, including aspirin, which will make the blood less sticky, so the blood will not tend to want to stick to cholesterol plaques in the heart arteries. We have cholesterol-lowering medications known as statins that can prevent further plaque buildup inside the heart arteries. Beta blockers, such as metoprolol, can help lower the resting heart rate and help the heart to fill with blood. And then we also have nitroglycerin, which is a medicine that can help dilate the heart arteries and improve the blood flow to the heart muscle. Finally, you may ask, well, why don't we give estrogen to prevent heart disease if estrogen has so many positive effects? Well, there have been studies done that have looked at this issue particularly, and it turns out the results are somewhat mixed. Postmenopausal women who are more than 10 years out from menopause tend to have more blood clots, strokes, and heart attacks if they're given estrogen replacement therapy. So we do not recommend estrogen replacement therapy just for the prevention of heart disease. However, if women are suffering from menopausal symptoms like hot flashes and night sweats, we do tend to recommend the lowest possible dose of estrogen for the shortest amount of time. We definitely don't recommend giving it if someone already has a diagnosis of cardiovascular disease, however. And so that basically concludes my talk, so I'm happy to accept any questions you may have at this time.
Thank you, and as a reminder, feel free to submit any questions you have in our Q&A section. Right now, we do have a question for you. What are 3 key foods that we should be aware of so we can include it in our diet for heart health?
Well, in terms of food for heart health, I usually fruits, avoidance of red meats, avoidance of a lot of dairy products, and whole grains. Whole grain pasta, whole grain bread is important.
Great. Should my target blood pressure be the same as my husband's?
Yes. There is no difference between goal blood pressures among men and women. We recommend a goal blood pressure of less than 130 over 80 among men and women alike.
Okay. And I currently have a teenage daughter. At what age should we start being more cognizant of her heart health and knowing that we have maybe a family history of this?
I think any adult over the age of 18 should have routine care by a primary care physician. Get the cholesterol levels checked, blood pressure checked, blood glucose levels checked, and by knowing these risk factors, we can intervene at an early age. Typically, patients don't tend to have much and intervene on those risk factors as early as possible.
Okay. And if I'm young and physically fit, do I have any need to worry at all about heart health?
Well, yes and no. I would say, again, it comes down to risk factors. If you're young and fit, but you have a strong family history of heart disease, it's really important to have your cholesterol numbers checked, have a look at your blood pressure to know what your risk factors are.
Great. I think that's all the questions. Oh, I think we got two. Hold on one sec. Does blood pressure medicine cause weight gain?
It should not directly cause weight gain. Some blood pressure medicines can make us feel very tired. That's a great question. So they say about 150 minutes of moderate aerobic activity per week. So I usually say about 30 minutes, 3 to 4 times a week.
Great. I think those are all the questions that we have. We appreciate everyone joining us today. We will be having this meeting that's virtual here recorded, so we'll be sharing that here momentarily. But we hope you can join us next month. Thank you very much.